All right. Good morning, everyone. Thank you for inviting me here. I'm happy to be here. I have a couple questions for you guys first. How many people in this room are perfusion students right now? All right. You're saying too far back. You should be in the front. How many people are practicing perfusionists? Okay. A lot of people. How many people are surgeons in the room? Okay. How about anesthesiologists? Right on. Well, I want to talk a lot about philosophy today, and I want to challenge everybody in the room, especially the students, to think about what can be and what they can achieve in the future. Like we talked about a minute ago, we're talking about precision, and we're talking about accuracy, and we're talking about everybody, every case, every day, regardless of whether the patient is 800 grams or 100 kilograms. I work for the University of Texas at Austin, and we believe that what starts here changes the world. I have no disclosures, but I want you to be challenged to let what you learn here change your mindset about what's possible and what you can achieve with your experience and this process that we'll talk about with reviewing and then refining your craft. So again, we work at the Texas Center for Pediatric and Congenital Heart Disease. You just saw this picture a minute ago. It's one of my favorite pictures. It's a little baby. He's a few months old, and it shows their hands with their arterial lining, a peripheral IV, their pulse ox. It's got a little positioning roll on it, and it's taped perfectly on the arm cord. And that's the kind of care that we deliver to every patient, regardless of whether they're a 4-month-old baby or a 70-year-old man. So there's our patient that Dr. Fraser talked about earlier, who is sitting in his bed post-operatively in the pediatric ICU. He's got a pacifier around his neck on a necklace because he was just kind of celebrating that he might be the oldest patient in our ICU, which he was. These are outcomes and age distribution from 2023. We take care of about 8% adults in 2023. We had 23 adult patients in 2023, coincidentally, with 0 mortality. And these are my suggestions for what you can achieve. You've got to rethink and reframe adult congenital heart surgery. I would suggest that we apply the precision and accuracy of our neonatal management to our adult patients. Bring your best to the operating room every day, and then refine your craft through a review of cases and continuous improvement, and really thinking about how you can push the envelope on what you're doing. I'm going to talk about 2 patients who underwent a Ross operation in our program in 2022. A Ross operation is a pulmonary autograft aortic replacement, and it's often done in patients with aortic valve disease that includes aortic insufficiency or aortic stenosis. This patient, the first one, is not our first Ross, but it's the first patient that I'm presenting. Is a 14-year-old male with predominantly AD. His weight was 50.5 kilos. He was 166.5 centimeters tall. He went to sleep uneventfully. He had his lines placed. We went on bypass uneventfully. The bypass time was 230 minutes. Cross-clamp time was 192 minutes. He received no blood products intraoperatively or postoperatively. He received a cell saver of 407 milliliters. And he did receive fibrinogen concentrate of 45.5 milligrams per kilo, which is kind of like what I like to do routinely with aortic surgery, especially in the blood conservation area. This patient was extubated in the cardiac operating room. His length of stay was 5 days. Now, this was the first Ross operation that I extubated in the OR. And I've done a lot of them. And I thought to myself, well, why wouldn't I extubate him? I mean, he's had an uneventful surgery. We've paid meticulous attention to hemostasis and operation. Our pump time is predictable, and I end up where I think I'm going to end up at the end of the case. We shouldn't be bleeding. Why wouldn't I extubate him? So I did. The second patient is a 46-year-old female with aortic stenosis, 65.75 kilos, and 159 centimeters tall. So is she different than the 14-year-old? And should the perioperative management differ? Should it differ surgically? Should it differ with regard to perfusion? Should it differ with regard to the anesthetic care that I provide? And that's where I disrupted my thinking completely. I thought to myself, oh, this is an adult patient. Of course we would leave her intubated. Of course, it's a different operation. It's a different strategy of an anesthetic. But then I grounded myself and I thought to myself, well, this is sort of like anesthetizing myself for a Ross operation. How am I different from a 14-year-old? Well, I'm pretty different. But size-wise and operation-wise, perfusion-wise, it shouldn't be that much of a stretch. So our bypass time was very comparable, 247 minutes, cross-clamp time of 203 minutes. Again, she received no blood products. She received her cell saver of 283 milliliters, and then she received also fibrinogen concentrate of 52.5 milligrams per kilo. She too was extubated in the OR, and her length of stay was 4 days. So to me, this was a difference in my perceived expectations of this patient and then what we were able to do. So if you look at the patients side by side, 14 and 46, similar weights, bypass time similar, cross clamp similar, no transfusion, both extubated, cell saver transfused, fibrinogen concentrate empirically, and hospital length of stay 5 and 4 days for each. Not really that different. And what I challenge you to do is not to think of them differently. So precision and accuracy, I think that we should apply the same principles, precision and accuracy, to the adult congenital heart surgery patient that you would bring to the neonatal patient. And that was kind of a difference for me. When I think about the drugs that I give, midazolam, fentanyl, vecuronium, I would say that when you go on bypass, you give each of these drugs as you're diluting them when you go on. And I actually have started to rethink how much I give when I go on bypass. I used to be able to go on and give 5 cc's of everything, but that doesn't make sense. If we go on with a neonate, I would give, milligrams per kilo. So I kind of had to rethink that or reshape how I provide that care. The picture on the right is somebody holding an infant's feet, and they hold them with care and gentleness and acknowledging their fragility. That's the same way that we take care of an adult, with the same kind of delicate hands and delicate care. And I think those are important things to see when you go from taking care of babies to adults, and maybe all adults. I think all adults should be treated that way, with care and respect and gentle hands. This is another patient that we took care of recently in the pediatric hospital, a 78-year-old man who presented for a repair of a coronary sinus ASD and a maze operation. He was 94.75 kilos and 183.5 centimeters tall. This is not a patient who I would have fast-tracked 5 years ago. I would not have considered the possibility that extubating him on the table was a good idea. His bypass time was 113 minutes. His clamp time was 81 minutes. He received no blood products. He received his cell saver of 710 mL. He was a tall guy. He was extubated in the cardiac operating room, and his length of stay was 5 days. So I think that, I've challenged myself to think, how does this patient differ from anybody else? Why wouldn't I extubate a relatively healthy, mature adult patient who's not bleeding and, not all that different from a child having the same operation. So it's kind of blown my mind in how I think about these operations. This is about bringing your best to the operating room. When you are doing a case, review the case, plan for the case, think about what you're going to do preoperatively, intraoperatively, postoperatively, from an anesthetic standpoint, a surgery standpoint, perfusion standpoint. You should be familiar as a perfusionist with the operation and the philosophy that your team brings to the table. And then refinement and continuous improvement. What does that allow you to do? It allowed us to establish a formal enhanced recovery after surgery pathway for adult patients. We've developed, great perioperative alignment to support in the OR extubation of complex cases like the Ross operation, patients having an LVAD, cardiac transplants. The young lady that Dr. Fraser talked about was her aortic root replacement at Fontan. I mean, that's pushing the envelope on that, but that requires expectations. It requires planning your anesthetic days in advance to be able to execute on that. And then also the perioperative psychological safety to be able to push the age limits. If you don't feel like you're going to be supported institutionally by doing these things, you're going to be less likely to do it. And so I think that aspect of a heart center has to be kind of planned out in advance so that you can execute on this type of practice. So again, my suggestions are that we rethink and reframe adult congenital heart surgery. We apply the same precision and accuracy for neonatal management and adult management. Bring your best, be prepared, challenge yourself, and then also to refine your craft through review and continuous improvement. As always, I'm grateful to be able to do the work that I do. I'm grateful to be here, and I thank you all for inviting me again. And I'm happy to answer any questions after the session.